D. Alan Shewmon, MD, Chief of Neurology at Olive View UCLA Medical Center, and Clinical Professor of Pediatric Neurology UCLA, Board Certified in Clinical Neurophysiology and Psychiatry Neurology.
First of all, let's talk about the physical reality of this thing called brain death. The brain, like any other tissue of the body, when it's injured, swells. What's unique about the brain is that it's enclosed in a hard shell called the skull. And so when it swells, obviously something has to give way. And at first what gives way is blood and cerebrospinal fluid. After a while, that compensation doesn't work, so the intracranial pressure builds up. And it builds up very quickly because the skull is rigid. So as the pressure builds up, here it is. The blood flow goes down. But the brain needs blood to stay healthy, so there's more brain injury due to the lowered blood flow. That causes more brain swelling. So you get a vicious cycle, the end point of which, in theory, is no blood flow and total infarction or destruction of the brain. So that is the physical reality that we're going to be talking about. Now, there's a semantic ambiguity with this term brain death, because it can either mean death of the brain as an organ, just like you can have death of a kidney or death of a finger from gangrene or something. And that is simply total brain necrosis, and clinically it would be manifested as a deep coma. Or the term can mean death of the patient by virtue of critical brain pathology. Now, the President's Council on Bioethics, in its recent white paper, prefers the term total brain failure to the term brain death. There's a whole chapter in its monograph about semantics and terminology. And it says, this ambiguity is most unfortunate. Let's get rid of that term altogether and talk about total brain failure. And then everybody's clear about what we're talking about. And then one can debate whether total brain failure is human death or not human death. But at least the terms are clear. In the rest of this lecture, I will use the term brain death because that's kind of ensconced in everybody's vocabulary, and it's in the literature and everywhere. You'll also see the term total brain failure. I'm using them equivalently. So the notion that total brain failure is death was introduced in 1968 by the Harvard Committee on Brain Death. Now, obviously, that's a very radical change in the statutory definition of death and everybody's understanding of death. And I would propose that any radical socio-legal medical change ought to follow this sequence on the left. First, there should be a consensus as to the radically new concept. Then the concept should be applied to biology and medicine. Then medicine would develop diagnostic standards for it, and once that's done, then revise the statutory law accordingly, and then implement the new practice. Now, if you look at the actual history of brain death, the first thing that happened was implementing the new practice. What was that? Transplantation of hearts and other organs from brain-dead donors. Now, so that the transplant surgeons wouldn't be accused of being murderers, the statutory law was revised to recognize brain death as legal death. After that, the medical profession started scrambling to develop diagnostic standards for it. All the while, there was an incoherent connection between the diagnostic standards and the mainstream concept. And I'll explain what the mainstream concept is in a minute. And there's still no consensus on the concept. I consider the equation of brain death with death to be a conclusion still in search of a justification. Now there are, up until the President's Council, which is this last one, all along the history of this, there were three competing rationales for why brain death was supposedly human death and not simply a deep coma in somebody who's dying. The first reason was that proposed by the Harvard Committee itself in 1968, loss of conferred membership in human society. So this is a sociological, society-specific definition, and the Harvard Committee chairman wrote that, well, society can define death however it wants. If it wants to define it in terms of brain function, that's fine, if it suits the purposes of that society. Another rationale that has been proposed and advocated by very many is loss of essential human properties, or loss of personhood. And this is a psychological, species-specific rationale. It applies only to Homo sapiens, not to animals. And it corresponds to what is known in the literature as the higher brain death concept. In other words, it doesn't matter whether there's breathing or pupillary reactivity or many brainstem functions, as long as there is no consciousness, there's no personhood, and therefore that person is dead. Well, this is the implicit rationale of many advocates of whole brain death. Finally, we come to what has been the mainstream rationale, loss of somatic integrative unity. So this is a biological, species, non-specific rationale. It corresponds with the British notion of brain stem death and the US notion of whole brain death. The President's Commission in 1981 advocated that rationale. All the Christian organizations that have supported the concept of brain death accept this rationale. And it is certainly, of all the three, the most compatible with a traditional worldview of things. So it's basically saying that without brain function, the body disintegrates. It's not a living organism anymore. It's just a collection of organs. So the President's Council on Bioethics studied all of this and concluded that none of these three rationales held any water. And it came up with a fourth rationale, and I have to give them credit for coming up with a novel rationale after so many decades of brain death debates. And their rationale is loss of vital work or self-preserving commerce with the environment necessary for organismic wholeness. Whoops. So brain death is not a settled issue. Let's see if I can go back to that. There. So if I've done this with many colleagues, and you can do it too with your colleagues and friends, just ask them why they think brain dead organ donors are really dead. And whatever they tell you, probe a little bit, I guarantee that you will come up with some inconsistencies and incoherencies. For the sake of time, I'm not going to go into all the details, but this was a teenage girl who had a malignant brain tumor that finally ended up causing brain death. And she was diagnosed as brain dead at a hospital in the East, which does a lot of transplantations, and the neurologists there are very expert at diagnosing brain death, and she was brain dead. She had no cerebral blood flow, flat EEGs, etc. There's her scan after almost a year in that state. That thing coming out the front of her forehead is residual of her malignant brain tumor under the skin. So she had temperature, lability, and you can see back here, this has become brain dead. Back on day minus 25 or so, you see where the temperature drops down really low. That's probably when she became brain dead at home on a ventilator, and then was only diagnosed when they took her to the emergency room because of a ventilator problem. And they did a brain death exam and formally declared her brain dead then. Here's blood pressure and heart rate, and you can see the lability of it. But what I want to point out is that during that first month or so, look how it stabilized. Came up all by itself. That, time and time again with this kind of a case, it had that pattern. And I think that reflects the recovery from spinal shock and the spinal cord taking over the function of blood pressure regulation. So, physiological evidence of somatic integration in these three and other cases that I'm not telling you about. So they have, thank you, they have homeostasis of a countless variety of mutually interacting chemicals, macromolecules, physiological parameters through the functions especially of liver, kidneys, cardiovascular and endocrine systems, but also of other organs and tissues. Intestine, bone and skin and calcium metabolism, cardiac atrial natriuretic factor affecting the renal secretion of renin, which regulates blood pressure by acting on vasculars. See, all of this is still interacting and keeping the body as a whole organism. There is elimination and detoxification and recycling of cellular wastes throughout the body. There is energy balance involving interactions among liver, endocrine systems, muscles, and fat. There's maintenance of body temperature, albeit lower than a normal level and with help of a blanket. But if you put a blanket on a corpse in a morgue, it doesn't maintain temperature. These individuals exhibit wound healing, the capacity for which is diffuse throughout the body and which involves organism-level teleological interaction among blood cells, capillary endothelium, et cetera, et cetera. They have fighting of infections in foreign bodies through interaction among the immune system, lymphatics, bone marrow, and microvasculature. Some develop febrile responses to infection. There is cardiovascular and hormonal stress responses. I already mentioned this, to anesthetize incision for organ retrieval. Now, obviously, that's not exhibited in these three cases, but in others. There is successful gestation of fetuses in brain-dead pregnant women. One of the children that I personally examined began puberty in the state of brain death. And if brain death occurs in childhood, they have proportional growth. I call it proportional growth as opposed to the growth of a malignancy, which is chaotic. Okay? These cells grow and maintain the bodily proportions, indicating to me that there is a wholeness about the organism, unlike a tumor. And I put at the bottom this table of holistic functions. This is from the President's Council on Bioethics 2009 white paper. Okay, it's not just my own ideas. And I would add to all of that recovery from medical crises, congestive heart failure, hypotensive shock, infections, and the overall ability to survive with little medical intervention in a nursing facility or even at home. So the President's Council put in its white paper, in such cases, globally coordinated work continues to be performed by multiple systems, all directed toward the sustained functioning of the body as a whole. If being alive as a biological organism requires being a whole that is more than the mere sum of its parts, then it would be difficult to deny that the body of a patient with total brain failure can still be alive, at least in some cases. So according to the President's Council, two possible positions remain. Position one, there is no sound biological justification for today's neurological standard. And position two, there is a sound biological justification for today's neurological standard, but it's none of the three that came before. It's none of those three rationales that I showed you at the beginning. But the novel rationale proposed by the Council, the fundamental work of the organism as a whole is commerce with the surrounding environment. An irreversible loss of that work is death, and a reliable criterion of that loss is the irreversible cessation of both breathing and consciousness. Well, I have many problems with the Council's position too. There's a confusion regarding wholeness. If you read their monograph, they propose that there's such a thing as unity without wholeness, which doesn't make a whole lot of sense to me. Wholeness is defined in terms of external work, and immanent self-preserving work doesn't count. There's a conflation of physical necessity for staying alive in the wild with the logical necessity for being alive ontologically. And there's the conflation of necessity and sufficiency of irreversible loss of both consciousness and breathing as signs of death. And there's ambiguity whether the vital works at issue are actual exchange with the environment versus an inner drive to such exchange. A good counterexample is a fetus in utero that has none of the things that the Council proposes are needed to be alive, namely consciousness and breathing. And there's a logical disconnect between apneic coma as the conceptual essence of death and the requirement of total brain failure. So many problems with this. So I maintain that some brain-dead patients may indeed be dead, but not because their brains are dead, rather because of supracritical multi-organ damage, including the brain. Unfortunately, this dead subset of brain death can be distinguished from the live subset only in retrospect after their rapid downhill spiral to asystole, which is the first stage in their disintegration. Now, go back to that first slide of the vicious cycle. I said it ended in no blood flow and total brain infarction in theory. Along the way, when you go from normal blood flow to no blood flow, mathematically the brain has to pass through a stage in which there is very little blood flow, not enough to support function, but enough to support tissue viability. And in the stroke literature, this is called the ischemic penumbra. And the whole effort of stroke therapists now is to save the brain tissue that's around the stroke that is in the ischemic penumbra. Now, if that occurs to the tissue around a stroke, well, all the more must it occur on the way to total brain infarction, involving the whole brain, i.e., the brain passes through a period of time when clinically there is no brain function. You do an EEG, it'll be flat, but the brain is not irreversibly damaged. Now, part of the diagnostic criteria for brain death is an apnea test. You have to determine whether there is spontaneous breathing. And you do that by hyperoxygenating the patient, taking them off the ventilator, and allowing the carbon dioxide pressure to go up to a range that should stimulate respiration if they're going to have respiration. And you observe that there's no spontaneous respiration, then you reattach the ventilator. Now, every brain death exam is supposed to include an apnea test. There are systemic complications to apnea tests. It induces acidosis, hypotension, cardiac arrhythmias, and cardiac arrest, and pneumothorax. It doesn't in most cases, but these are definite risks. Now, more importantly to me is there are neurologic complications that nobody talks about. Because if the patient is in the ischemic penumbra stage, when you do the apnea test, if they're not already brain dead, you're going to make them brain dead. So I have come to believe that the apnea test is an intrinsically unethical procedure. It offers no benefit whatsoever to the patient to outweigh the substantial risks. The intention of doing the test is to benefit not the patient, but someone else, i.e. an organ recipient. And informed consent is never sought or given for an apnea test. We heard about informed consent in the previous lecture. Now, what are the implications of all of this for transplantation? Well, either we keep the dead donor rule, and I want to quote from the President's Council, which I think is the most remarkable quotation coming out of a government-sponsored agency that I've ever read. If indeed it is the case that there is no solid scientific or philosophical rationale for the current whole brain standard, then the only ethical course is to stop procuring organs from heart-beating individuals. President's Council on Bioethics. I'm not going to bother reading what Pope Benedict said, but more or less along the same lines. The other possibility, of course, is to abandon the dead donor rule. And there are more and more protocols of donation after cardiac death, or also called donation after circulatory death protocols. I don't have time to go into that, but this is a legal fiction to call that state death. And more radical proposals by especially Frank Miller and Robert Trug in Boston, that they say, yeah, of course these patients aren't dead. Everybody's known that all along. Let's, face the facts. They're as good as dead. Those organs aren't going to serve them any purpose. Why not give them to somebody who could benefit from them? So, informed consent for organ donation. I maintain that informed consent for organ donation has never been obtained by the transplant industry in its entire history. Pope Benedict wrote, "Informed consent is a precondition of freedom, so that the transplant can be characterized as being a gift and not interpreted as a coercive or abusive act. For this, it is useful to increment interdisciplinary research and study in such a way that the public is presented with the most transparent truth on the anthropologic, social, ethical, and legal implications of a transplant." Well, after the business about the cigarette industry, we now require warnings on cigarette ads. So why not also for organ donation ads? It remains controversial whether you will actually be dead at the time of removal of your organs. This depends on the conceptual validity of position 2 in the analysis of the determination of death conducted by the President's Council on Bioethics. You should study it carefully and decide for yourself before signing an organ donor card. Thank you.